Okay, good morning. And it's a beautiful morning out there. Sun is shining, blue sky. And here I am again talking about neurological emergencies. I'm Marion Williams, and I'm a nurse. Okay, sorry about my voice this morning. I guess I need more sleep, right? That would help my voice. So anyway, let's get going here and we'll talk a little bit more about neurological emergencies. I did the intro to neuro yesterday, and hopefully you were able to um, recall that information because we're going to expand upon it a little bit. So, as far as our objectives are concerned, it's describing how you determine LOC or level of consciousness, signs and symptoms of meningitis, stroke, TIA, presyncope, syncope, and generalized and focal seizures, and hypoglycemia and status epilepticus. So, we're going to go and start on this information. So your brain, like I told you yesterday, needs three things. It needs, you can go ahead and say them, oxygen, glucose, and sodium. Okay, so if we lose consciousness, we likely have lost one or more of these, right? Maybe I don't have enough oxygen to my brain, maybe not enough glucose, and maybe not enough sodium. The other thing, of course, is if you have a traumatic brain injury and you've lost your blood in your head, that's going to be a whole nother thing. So as far as our blood supply to our head, we get the blood supply from the internal carotid arteries. It's from the common carotid artery, which comes out of our main aorta. And there are two vertebral arteries. Sorry about that. It's my fan club, they're calling. Then we have a circle of Willis, which is here. It's our circle of Willis. So we have the common carotid arteries, we have the vertebrals, and then they go up into the circle of Willis, which is a really important circulatory system in our brain. So not only do we get blood to the brain, we also bring blood back. And if there is a venous system, of course, in our brain that brings the blood back to be reoxygenated, and then our oxygenated blood goes up via the vertebral carotids, vertebral arteries, etc. So I did talk about this before, and this was when I did the intro to neural. It's cerebral perfusion pressure. And maybe these figures are slightly different than what I told you yesterday, but the normal cerebral perfusion pressure is somewhere around 60 to 160. Like I said before, the brain is very able to maintain its own cerebral pressure to a certain limit, irrespective of what goes on down the rest of our body. But if your cerebral perfusion pressure goes below 60 or above 160, then there is an issue. Then it can no longer maintain its own cerebral perfusion. Remember, the MAP is mean arterial pressure, and that should be somewhere around 70 to 100 millimeters. Normal ICP or intracranial pressure is around 7 to 15 millimeters of mercury. So therefore, the only thing you and I can really put our finger on in the field is MAP. I told you how to figure it out by yourself. and that is systolic blood pressure plus, systolic blood pressure times 2 times the diastolic pressure divided by 3. Um, no, I said that wrong again. Beg your pardon. Take that all back. Systolic blood pressure plus 2 times the diastolic pressure divided by 3. So that's how you could come up with your map. If your map is within your 70 to 100 millimeters of mercury, then you know that at least that figure is good. So if my map is below that or above that, there probably will be repercussions to our cerebral perfusion pressure, possibly to our ICP or intracranial pressure as well. But this is, you need to know this particular formula. So how does the brain show signs of injury? Because I can't take a natural pressure of the brain or anything, but I can look at the body. I can do an assessment. And so here's a bunch of different things, right? Maybe I have a severe headache. Maybe I'm not seeing appropriately. Maybe I'm not walking appropriately. Maybe I can't speak well. Maybe I have trouble swallowing. Maybe I'm paralyzed on one side. All kinds of different things will give me an idea, oh, there's something going wrong up here in my brain. So seizures, obviously that's going to be something that tells you there's a problem in your brain, and changing the level of consciousness. Now that is a really, really important red flag. Do I have a change in consciousness? Is the patient no longer awake, alert, and oriented? And these localized signs, like I was just saying. So assessment of the neuro patient. So consciousness, like I said, very, very important. Change in consciousness is a very much a red flag. So we're going to interview the patient. Okay, is he awake, alert, oriented? Gives us a great idea. We're going to do a physical exam, and that's going to include movement of all his extremities. It's going to be a pupillary assessment, and you want to see whether or not he can walk by himself. Can he or can he not walk? Is the on both sides of his body, is there equal grasp? Is there equal movement, etc.? If he's unconscious, you want to look around. Okay, if he's by himself, it's a little bit more of a challenge because he's not going to be able to answer your questions if he's unconscious. If there's family around or other people who have observed him, that's fabulous. You can get some information from them. However, the other thing is look around to him, on him too. Does he have a medical alert necklace, a bracelet? What do you see if you're at his home? What do you see for medications? That sort of thing. You want to interview the bystanders and see what kind of information they have before the incident and what he was like then. Your neuro exam after your airway, breathing, circulation, we're going to start getting vital signs, okay? Pulse ox is going to be important. And the blood sugar is very important. Now, that's a necessity. If we have a patient who is altered, then we need to know what their blood sugar is, okay? Because if their blood sugar is low, it could be as simple as giving them D10, dextrose 10%, right? That's great. I hope that's all it is. Okay, but at least we're going to get their vital signs. Glasgow Coma Scale, and that's important for you to know. and for you to know by heart, right? Now, you may have time to pull out your phone and look and see and make an assessment. What is his Glasgow Coma scale? Is it 15 or is it lesser than that? And which parts of the Glasgow Coma scale are not meeting the absolute excellence? So pupil assessment, like I said, I want to know whether or not the pupils are equal in both eyes. Do they react to light the same way or do they not? Is one a rogue pupil and one okay? Are they dilated? Do they respond to light? Fixed and dilated is a bad sign. Okay, and one pupil may be different than the other. Note that. Very important point. And we're going to do a stroke assessment. And those of you in LA County, the stroke assessment is very well laid out in your protocols. Okay, here's a Glasgow Coma scale. And my suggestion to you, if you don't already have it memorized, memorize it. You're going to need it every day in paramedic school and every day out in the field. So know it backwards. The sooner you learn this stuff and have it committed to memory, the better it is for you, the easier paramedic school will be. So I think you're all fairly familiar, at least, with the Glasgow Coma scale. So here's some pupillary pictures to just show you. A disconjugate gaze means I'm talking to you, but the eyes are going an opposite way. That's not appropriate. Pinpoint pupils, and when you look at your little scale, you will see the pinpoint pupils are 1 and 2 primarily millimeters, right, on your pen light. When it gets to be 4, 5, 6, you know that you have dilated pupils. So don't be disturbed by that. So if you get a question, for instance, and says the pupils are 2 millimeters, you're going, what's 2 millimeters? Well, look at your pen light. You can see that that is pinpoint pupils, and that's not a good thing either. So that shows that there is brain injury. Bilateral dilated pupils, not a good thing. Okay, it means that likely means that there is significant brain injury. Unilateral dilated pupil, again, no dilated pupil is good. But if I have one pupil that's normal, that's we're on the way to health, hopefully. But it's all usually because it's something that's going on in the brain. And why could it be going on in the brain? Sometimes there's medications that we give that cross the blood-brain barrier that I explained yesterday. So here is the Cincinnati Pre-Hospital Stroke Scale, and probably you're all familiar with that. It has the 3 assessments: facial droop, arm drift, and abnormal speech. So that's something that you need to assess and you need to document. Okay, so the LA Motor Scale, the LAMS score, which is what we do in LA County, it takes that Cincinnati Pre-Hospital and then it assigns it an actual value. So it's really, look at how sensitive it is. 8 out of 10 times, it's very sensitive. Is it specific to a stroke? Well, 9 out of 10 times it is. So 9 out of 10 patients is going to be very specific that it's a stroke, that the patient has a stroke. Okay. So what are some strokes? We basically have two types. Looks like we have four, but only two types. And one is an ischemic stroke. That means there is decreased blood supply to an area of the brain, just like ischemic heart, right? Decreased blood supply. Hopefully, we can increase the blood flow there, and so it doesn't go on and become an infarct, okay? So, stroke, an ischemic stroke is going to be a great number of your stroke patients that you pick up. Probably in the vicinity of some 6 to 8 out of 10 patients that you pick up that have a stroke and are probably going to be ischemic stroke. Why? Generally because as a after injury from chronic hypertension. Not always, but it could be. Mostly could be. And then there's a hemorrhagic stroke. Okay, and that's where there's a bleed in the brain. So that is probably somewhere between 2 and 3 out of 10 patients that you pick up probably are going to be a stroke because they have a hemorrhage. You and I out in the field don't know, is it an ischemic stroke or is it a hemorrhagic stroke? So we can't go ahead and do a whole lot out in the field because I don't know which it is. I'm not going to give aspirin because it will cause possibly cause some bleeding, right? So if I give aspirin, I don't know if it's hemorrhagic or an ischemic stroke. So that's an issue. So in ischemic stroke, it's usually clot. And we talked about clots yesterday, and it gets lodged in one of the vessels in the brain, and it can cause a stroke. So if that vessel is totally occluded, any of the tissue distal to that clot will either be ischemic, and if it's over a period of time, will die. And so the patient will have sequelae from that. So the four key elements of strokes, usually rapid onset. Okay, we don't know when it happened. Say they went to bed last night, they were just fine. They got up this morning and they can't move one side of their body. When did that happen? Did that happen when they woke up, or did it happen sometime through the night? We don't know. But most of the time, the stroke happens fairly quickly. Someone is eating breakfast or lunch, and all of a sudden they slump over. That would be a rapid onset. They usually have signs and symptoms of neurological impairment. Like we were saying, their Cincinnati pre-hospital scale. You do that and you find there is some impairment. And strokes are different than TIAs, transient ischemic attacks. And I'll mention that a little more detail in a minute. Underlying cause is usually due to dysfunctional blood vessel. Is there a clot in there, or did a blood vessel burst and there's now bleeding in the vein, in the brain, excuse me. So signs and symptoms, we need to evaluate any neurodeficit as if it's a stroke, right? We're going to do our assessments. Cincinnati Pre-Hospital, our LAM scale. Abrupt onset is significant weakness, numbness, or tingling on one side of the body. Could be in face, arm, leg. Usually, it affects the entire one side, not just say they have facial droop. Now, just a facial droop is usually something else, another process, which I can talk to you about another time. Okay, and what about their level of consciousness? Are they awake, alert, oriented? Are they able to speak? Or are they just looking at you with a vacant stare? And they may have a vision loss depending where the stroke is. And remember, I said in the occipital area of the brain, oddly enough, that's where your visual uh, ability comes from, is your occipital area. Are they nauseated and vomiting, headache, trouble speaking? Especially in a ruptured vessel in the brain, a hemorrhagic stroke. They're really sick in that they start to vomit and they have a headache that is just beyond something they've ever had. They may have aphasia, trouble speaking, and they can't pick up something easily, and they maybe go for it like this, okay? So it's movements that are not defined. So what do? You're going to go to a stroke facility. Why? Because they have the neurospecialists that can go in, depending where the clot is. Sometimes they can go in the blood vessel and pull out the clot. Sometimes they can go in and with medicine and dissolve that clot. Okay, that's way beyond my expertise. I wouldn't even know where to start. And sometimes then they can also go in, and if there's a bleeding or a leaking blood vessel in the brain, sometimes they can tie that off. And so they can stop the bleed. So there's so many things that they can do nowadays, which weren't being done in years past. And so people, once they had a stroke, were like, it was almost hands off. What can we do now? We can't do anything. So the patient gets to go to an assisted living facility or a nursing home, and that's where they are for the rest of their lives. How horrible. I mean, not that nursing homes are necessarily that horrible, but what an existence for them. I feel so sorry. Um, but now we need to get them to a stroke center and have the specialists go in and take care of them. So we're going to keep the patient with the head elevated. Why? Well, it promotes venous drainage. Okay, so that if I have them laying down or even head down, what's going to happen is there's going to be increased pressure in their head from the fact that we're not letting the veins in the head drain down back to the heart. So we're going to keep them in a semi-Fowler's position, and we're going to keep their head in one position so that they're not moving it like that and possibly causing a vein being cramped or kinked a little bit. We're going to try and maintain the map at least 60 millimeters mercury. And because, remember, I said cerebral perfusion pressure is so important, the only thing you and I can really deal with is the map, right? So we need to keep it at least 60 millimeters of mercury. If their temp is elevated, we possibly could give Tylenol. We're certainly not to give aspirin because aspirin can cause more bleeding, right? Thins out the blood. Your purpose is good. You want to disintegrate that clot if it's a clot, but we don't know if it's a clot out in the field. And we're going to control seizures according to our protocols. So in a transient ischemic attack, there is temporary disruption to the brain. Okay, because of the same old thing, right? It's the cholesterol buildup in the vessel, and it eventually the blood cells as they're going by cling to this irregular surface um, of the plaque there, and eventually they will adhere to this, and eventually they'll clot off that whole vessel. So that's what a transient ischemic attack does. But when a TIA is a temporary, when they say transient ischemic attack, they mean, okay, he has all the signs and symptoms of a stroke. However, over a period of 12, 24, even 48 hours, all the adverse symptoms disappear. And that's great. However, we need to have that patient being taken care of in a facility because they may need to go in and rotor-rooter, so to speak, and take out that unhealthy plaque right there, that fatty plaque, and open up that vessel. So if they have a transient ischemic attack and there isn't a good research on why they had this attack, they may have another one and another one. Before they had the neurological interventions, like I was telling you, they go in and pull out the clot, etc. Then people who had a TIA, often they would have more of them until they would have a full-on blown stroke. And usually that happened within 1 year of having the first ischemic attack. And you can probably think of people in your social circle, older people who probably had TIAs and then had some interventions in the hospital, and they're good as gold now. So what about syncope and near syncope? What is that? So pre-syncope or near syncope, and this is quite blurry, and I apologize for that. They almost lose consciousness, feel really lightheaded, and they may even have trouble seeing, okay, and where do I, they feel lightheaded, but they can't figure out where the chair is so that they can sit down, and they feel really faint, but they don't pass out totally. So that's pre-syncope or near syncope. Syncope is actually, they do pass out and they lose consciousness. And it usually comes on quickly, doesn't usually last all that long, and they can come back and, oh, what happened? Oh man, I felt so lightheaded. And who are you all? And why are you all here? And I'm just fine. You guys go back to your station and life will go on. But syncope is something that shouldn't be glossed over, and those patients need to be taken to the ER. So what are some causes of syncope or altered level of consciousness? And this is something you're going to have to know as well. And we do quiz you on this when you come to the paramedic school. We're putting you through different scenarios. We're going to ask you, what are the causes of altered level of consciousness? Okay, and it's AEIOU tips. Okay, there's lots and lots of reasons why they may have had a syncopal episode or are unconscious now. I need to try and figure out what are the reasons possibly they could have experienced this or are experiencing this. Okay, so we have types of them. Vasovagal. Okay, this is someone who is looking at the sight of blood and they faint, right? That is a vasovagal, right? So what happens, vasovagal, vasovessel, vagal, that cranial nerve number 10. So it starts to, when they see that, and all of a sudden they just become very, even pass out, right? What about a situational syncope? Okay, someone gets really bad news, like you have a very close relative that you just heard they passed away traumatically. That person may, in fact, have a syncopal episode because of the bad news. Now, let's just go back here for a minute. And here you can see that a psychiatric possibility, not because they're crazy, don't get me wrong, it's because that news has been too overwhelming to their system. So a carotid sinus syncope. Okay, so what happens, and you remember this, I told you there were baroreceptors in your carotids, right? I told you there's those tiny pieces of tissue in your carotids that sense pressure, right? So what can happen? You try and choke somebody, you put pressure here, you have too much pressure there, sends it to the brain and says, slow down the heart rate. So when you are feeling for carotid pulse, just an FYI, I've seen people do it like this with their thumb on the other side and they're really pressing hard, trying to feel a pulse. Just one side and don't press terribly hard or you can stimulate that baroreceptor. So that would be carotid sinus syncope. Now, sometimes the doctors do that and they massage the carotid artery to try and get that baroreceptor, tell the brain pressure's high, slow down the heart rate, because that patient may have a very high heart rate. And that could be one way they can bring down the heart rate. You and I don't do that. The reason for that is in that carotid artery, I might have a lot of plaque in there, right? And if I'm massaging that vigorously, I could cause potentially part of that plaque to break off, go up to my brain, and then given my patient possibly an ischemic stroke. So you and I don't do that. We don't live in Rancho Palos Verdes and drive a Maserati, right? Because they they're the specialists. They know what they're doing, and most of the time it's not an issue. Most of the time, so you and I aren't going to take any responsibility there. Orthostatic hypotension. Okay, some people, as you get older, when you go to stand up, you just take a little bit longer, and possibly your grandparents, you see that. The reason is because when you stand up, initially blood pressure goes down, right? And they may feel a little bit lightheaded. That's why they take their time getting up. And postural orthostatic tachycardia syndrome, POTS, actually, if we are assessing someone's loss of blood, we may, in fact, do orthostatic vital sign, blood pressure, pulse. When they're lying down, then we sit them up, we wait a minute, take their vital signs again. Is there a change? Is their blood pressure going down? And then we do it when they stand up again. And that's positive. If the blood pressure goes down, heart rate goes up from lying to standing, then we call that positive orthostatics. Um, Do we do that a lot? Yeah, we still do it. Um, but anyway, that's what that means. So, what are you and I going to do out there in the field? We're going to try and figure out a cause. AEIOU tips. Okay, so have that committed to your memory. We're going to do an assessment on the patient, right? Very much an assessment, actual good assessment. A, B, C, D, E, right? Our basic primary assessment. We're going to find out their history. What medicines are they on, if any? We want to know what people saw ahead of time, what happened ahead of time, what's a patient remembered just before he became unconscious, okay? Those are the things that we want to know. Vital signs, and remember I said anybody who has an altered level of consciousness, we're obviously going to get a blood sugar. That would be a fairly easy fix. We're going to address environmental concerns, heat and cold. Okay, I'm going to tell you a little story of how dumb, ignorant I was when I first came to California. As you know, I'm a Canadian, or as you may not know, I'm a Canadian, middle of the prairies, about 350 miles north of Minneapolis. And so I was always used to, it gets terribly cold in wintertime, 40 below zero, 45 below, whatever. And I come here and I get married, and my husband and I go for a short honeymoon. We go out to Palm Springs. Okay. And my whole purpose in life at that point was to get a suntan, get beautifully suntan, because it's hard to do that in Canada, and even in the summer, although it's possible. And so I lay out on this foam mattress all day long. I don't know what the temperature was, but it was hot. And I would just flip water onto myself, and I was out there all day long. Then I get out of the water finally, and I'm standing outside our hotel room, and all of a sudden I just go down, totally out. I'm not sure how long, couldn't have been long. And then I get up. My husband helps me up. You okay? Are you okay? You have to go to the ER. I'm fine. I'm fine. I don't know why that happened. But that happened because I was so dehydrated. I didn't drink while I was in the drink water. I don't drink alcohol, but I didn't drink anything while I was in there. So I was terribly dehydrated, and I was in this hot, hot environment, which I had never been in before, especially for that long a time. So environmental concerns could be the heat, it even could be the cold, very cold. Like if you went up there in the middle of winter and it's 40 below plus wind chill factor, um, you know, that does a number in our bodies. So you're going to place the patient lying down, because if you sit them up, it's possibility is their blood pressure can go down. You're going to give them oxygen. You're going to evaluate for hemorrhage and shock, obviously. Get a 12 lead and treat any dysrhythmias. Now, right now, of course, you don't well, I mean, you do 12 leads, but you're probably not many of you really can read them well, but you're going to cheer up. You're going to, and you can start IV and give the fluids, right? We said 250 milliliters, and then you reevaluate if they're an older person. Okay, don't go for it then. So now let's go on to something else, which is more disease oriented. Meningitis. Okay. Meningitis can be caused by viruses, it can be caused by bacteria. Just going to move my camera a little bit here. And it can be just give you a lot of discomfort or kill you, depending on the causative agent. So, usually have a severe headache and the neck is stiff. Okay, that's something that we look for. And the classic triad is nuchal rigidity, meaning the neck is stiff, sudden high fever, and altered mental status. Now, you may, in fact, have a rash. If there's a rash, there's something I want to mention to you about that. If you have a rash and you can't blanch it, meaning when I push on that rash, it doesn't lose its color. If it stays the same color when I push on it, that means it's not blanching. It's a non-blanching rash. That is a huge, huge, huge red flag. You put on your mask and gloves and you hightail it to the ER as fast as your little tires will take you. And that means that he has a severe case of contagious meningitis. It may be from the meningococcal family, and that is extremely virulent. I already told you about that young girl came into the ER, and that's what she had. She had this rash, nuchal rigidity, she had a high fever, and she was dead within 6 hours because it is extremely virulent. You go into septic shock, and many times we can't bring you out of it. So that's something you want to note. And if you ever suspect meningitis, mass, okay? Because meningitis is spread via respiratory droplets, okay? So make sure you wear your mask. And if the patient can tolerate, put a mask on them. Now, I was going to say something so important about that. Oh, yes. And if you haven't had a mask on it and then you decide, oh yeah, I think it's meningitis, then you need to tell your supervisors because you're probably going to have to be on prophylactic antibiotics. So your medical director will give you prescriptions for certain antibiotics to take so that you don't develop meningitis. Now, if it's viral meningitis, there's no treatment for it. You just have to kind of like deal with it. So meningococcal meningitis, and here we have part of the rash, and it looks like petechiae. That's small dots, okay? That's petechial rash. And like I said here, meningococcal rash does not blanch because when you put your finger on your skin and you press, it goes lighter, right? Well, it doesn't in meningococcal. And so they're really sick, high fever, terrible headache, have trouble focusing with their eyes, very, very sensitive to light. And petechiae, this is petechiae. I had a kid come in one time, and I'd never seen purpura that I knew of. And this kid was septic, but not because of meningitis. He was septic due to strep. He had a strep throat that wasn't treated, not because his parents were bad. They just didn't have medical insurance and they thought he'd just get over a sore throat, but he didn't. They brought him in. And he had petechiae, and then he had purpura on his skin. Like, what's that? And it looks like all these petechiae mesh together and become like, it looks like a bruise, but you'll know the difference between a bruise and that. And I'd never seen it, but I sure knew what it was when I saw it. And this kid was critical. He came in awake, sitting on his dad's lap, but he went downhill very quickly. Thankfully, he was able to be treated, and we did extensive things in the ER, and we didn't have a pediatric ICU at that time. And so he was sent to a facility that did have a pediatric ICU, and I found out he did fine with no bad sequelae. Okay, what about a seizure? If you've never seen a seizure, the first time you see it, you go, ooh, that wasn't pretty. Whoa, that seizure, they start like this, and then eventually they're like this, right? Or they start off like this, and then they go into this motor movement, and their eyes roll back, their head moves, and they continue that kind of behavior. It's really kind of scary, isn't it? So why do kids have seizures? Why do adults have seizures? Well, it could be a fever, could be from some infection. Now, they used to think that anytime a kid got a fever, he was potentially at risk for a seizure. But now they're saying that generally a seizure when a kid has a fever is because the fever went up went up high quickly. And so that's why they seized. Most kids will only seize once or maybe twice when they have a high fever, when their fever goes up quickly, and they never have a seizure again. And, and you and I, now that we're experienced professionals, we see a kid having a seizure, okay? And if the parents haven't seen one before, they're freaking out, right? And you and I go, well, it's a seizure. He'll get over it and life will go on, right? But parents think their kid is going to die. So there's a great dichotomy between what you and I see as a seizure and what the parents see as a seizure. And so we need to be very supportive of parents, especially for kids that have a seizure. Now, can you and I have a seizure, a first time seizure? Yes, we can. What are some causes? Well, it could be because I snorted too much cocaine, right? Or I'm withdrawing from some drug. What about a stroke? Ischemic stroke, hemorrhagic stroke, that can precipitate a seizure. Trauma to the head can precipitate a seizure. What about tumors, brain tumors? Now that's really devastating. Degenerative diseases, pregnancy complications like eclampsia. I'm going to talk to you about that later today. And that can cause a seizure. Metabolic disturbances, maybe your sodium is out of whack. And electrolyte disturbances, which is sodium's more of an electrolyte than metabolic. But I could have a metabolic disease, like some sort of renal disease that's causing me to have a seizure, or congenitally. Some kids are born because they have something going on in their head, like too much cerebral spinal fluid, right? Or they have just a congenital malformation in their brain or in their head, and they're going to have seizures the rest of their lives. So that is something that the parents, the caregivers have to deal with um, when they're taking care of their loved one. So 70% of seizures are idiopathic, meaning 70% of the time we don't know what causes it. And so we need the neurologist to come in and start looking for causes and doing all sorts of tests. And maybe they don't even know once they've done all the tests. So what are some classifications of seizures? Generalized is generally, like I was describing, the tonic-clonic type of seizure. And if it's generalized, it involves both sides of your brain. It's often associated with loss of consciousness. And then there are different types of your seizure. It isn't always a tonic-clonic. It may be just like this, or it may be just like this, or it may be, and I'm out of it for a few minutes. Actually, I have a cousin, and I don't know her well. And I was at her mother's house, and she was there, and we were all talking. Then all of a sudden, she goes like this for several seconds, and then she comes back. So she was having these absence seizures, and I never knew she had them before. So focal seizures is just one side of the brain or one area in the brain that is actually being involved. So usually with a focal seizure, they're awake, right? And they have possible changes in mentation, responsiveness, or their behavior. So what is the pathophysiology of seizures? Focal seizures begin in one location. Whoops, my phone is telling me about seizures. So they don't really know what the real cause is. They know causes a lot of times, but they don't know what happens physiologically in the brain. They think that there is a difference between the excitement of the neurons and the neurons stopping the activity, and then excitement, then inhibitory response, etc. They don't really know. So I'm just giving you some of the possible thoughts about the phys here. So what about a generalized grand mal seizure that we all know, the tonic-clonic? Preictal, they might have an aura, call it oral. They may know something is their seizure is coming on, like they may see a bright light. Maybe they have a severe headache and then they go into a seizure. And this is the ictal is their seizure activity. Following the seizure activity, they're in a post-ictal state where they don't have the seizing anymore, but they're not awake. Okay. And they usually have noisy, snoring respirations, and we put them on their side because they may have saliva coming out of their mouth. We watch them very carefully so that they don't injure themselves and don't stop breathing. But during the ictal phase, they do stop breathing and their skin color will change. And that's very disturbing to family members. And then eventually they'll go back to normal. So I mentioned the different types here. They're altered and their eyelids might flutter. My cousin, when she had the absence, she didn't do anything but just sit there and look. And the rest of us are continuing the conversation. Then she comes back and then she joins the conversation again. They may have grunting sounds, they may laugh, they may scream just before they have a seizure or cry. Now, you've heard of people walking in the middle of the street and they're naked as a jaybird. So that could be part of a pre-ictal type of seizure, or it could be the type of seizure they have. And they, we get real testy about this stuff. Okay, what on earth are you doing in the middle of the street? What on earth are you doing? They're in clothes. Help me understand, educate me. So, but it may be some neurological issue. So we need to give them a little bit of slack there. Automatisms. Okay, maybe that sort of thing. So watch for that. And ask the family, what are they like after they had the seizure? What are they like when they had the seizure? Explain to me what activity you saw. Now they're going to exaggerate the time of the seizure, how long the seizure lasted, because it's so traumatic. Okay, so just like us with an earthquake, how long was the earthquake? I don't, it seemed like to me like 3 minutes, and maybe it was 40 seconds. Okay, so when there's something traumatic, we have altered sense of time. And are they incontinence of urine or bowel? Many, many times in the ictal state, when they're actually having the seizure, they will pee into their clothes, okay? Or they might even have a bowel movement. The other thing they have with tonic-clonic is they bite their tongue or their lips, and you'll see blood there. That's a very good indication that they've had their seizure. So what do I do? First thing is safety, right? Got to keep my patient safe so he doesn't fall, hit himself on something hard or whatever. So I'm going to protect my patient. I'm not going to hold him because I can't stop that seizure, but I'm going to make sure he's in a safe place. Now, can I put in an endotracheal tube or an eye gel when he's actually seizing? No, I can't. I can't do anything except maybe have an O2 mask and holding it in front of him. But otherwise, I can't do anything. But I can do it after the seizure when he's in the post-ictal state. As paramedics, we can stop a seizure with medication, right? We have midazolam or Versed or other drugs that we can use. Midazolam in LA County is one of the most common ones we use. And start an IV, because you and I don't know whether or not he's going to have another seizure. So I would have a fast, quick way to give him more medicine to stop that seizure. Or now we have inhaled drugs, right? So I could put it in his nose. But if he's actively seizing, you're trying to put the nose medication in a target that's moving all over the place. And of course, we're going to check the blood sugar, because you can have a seizure when your blood sugar is really low. And I don't think in my experience I've ever seen someone with having a seizure with a low blood sugar. I saw a patient once, the lowest I ever saw for blood sugar was 20, and she was still awake, lethargic, but answered questions slowly. And so you can have a seizure with a low blood glucose. Now, that doesn't mean that the next guy whose blood sugar is 25, he might have a seizure. So it depends on the person. So here's your tonic-clonic. This is what your tonic looks like. And there's your clonic, the movement, right? And then they relax in the post-ictal. So an acute transient, less than 5-minute event is a seizure, excessive or asynchronous. So maybe some people will have one arm doing something, the other arm not doing that, the same activity. So you have to watch that person. You've got to remember what started first, what was next in their behavior, and if you have the presence of mind, timing it right. Okay, so you can have a focal seizure, and it depends. They are using all kinds of different language to decipher a seizure. Partial complex, simple complex, it's all over the map. So want you to document what you see and for how long. So epilepsy is recurrent unprovoked seizures, 1 to 4% of people. And people who have epilepsy like this are usually treated with certain medications to keep them from having more seizures. It may not totally take away their seizure activity, but it's going to drastically reduce it. And those who have a seizure activity or seizure, epileptic problem are usually not given a driver's license until they have a doctor's note and they've been without any kind of seizures for so many months, years. Partial tonic seizure is a focal seizure. It originates in the specific area of the brain. So partial tonic is maybe just the left side, or maybe it's just the right side. So that's what a partial or focal tonic seizure. So it's one spot in the brain that is causing this. Tonic-clonic is what we call the generalized grand mal seizure, and it can be due to a number of things. Hopefully, it's not the brain tumor. But if you have a patient who's had a head injury, it could in fact be that. Okay, so you want to watch your patients who have a head injury, and you know dramatically that they have had a head injury from the accident, and you're going to watch them for a seizure. So you're going to be proactive in making sure that the area around the patient is safe. For instance, you're in the back of the ambulance, you're bringing the patient to the emergency room. You don't know if he's going to have a seizure or not, but you have pillows there and maybe some folded blankets that would keep him from injuring himself inside the ambulance if he had a grand mal seizure. Of course, it can be from withdrawal and low electrolytes and a stroke, obviously, which is what we've been talking about. So here is your phases, your tonic phase, then your clonic, and then your postictal. So a petit mal, well, we use absence or petit mal, it's like my cousin, right? She just sat there and just looked. I don't know how long, I never asked any questions. How long she's been having absence seizures. She was a university graduate, held a very prestigious job. So I don't know how she performed with these absence seizures, whether she was on any medication. I don't know any of that, but that's an absent seizure. We used to call it petit mal. Okay, small. Mal is bad, right? So it's a small bad. It's not as bad as having tonic-clonic. So that's where that came from. Grand mal is big bad, right? Grand, big, mal, bad. So big bad seizure, tonic-clonic. So diabetic seizures, yeah, they can have a seizure with their blood sugar being low, eh? Less than 70 milligrams per deciliter is considered low blood sugar in an adult. May they have a seizure at 65 milligrams per deciliter? Depends on the patient, eh? And like the one I had with 20 milligrams per deciliter, she didn't have a seizure, but we sure gave her sugar in a hurry to make sure she didn't have a seizure. And why do they have a seizure? It's because either they took too much insulin or they didn't eat well, right? If they are on insulin, that is. So they need to eat properly, need to eat at prescribed times, and hopefully they can be okay. Now, if they are awake and they have a swallowing reflex, I can maybe give them something to eat or drink, right? But in our case, they're usually probably not awake and alert. So I've got to give them some sugar, right? Somehow. So I can give them D10, dextrose 10%, which is what you carry in an IV bag, or I can give them a glucagon injection. And that glucagon is in this red case. You're going to have to mix it together. Usually it comes with a syringe and then it comes with another little ampule. So you're going to mix it together. And then you're going to give it. We don't give any injections into the buttocks anymore because we may, in fact, give them hit the sciatic nerve and then you're in deep doggy doo-doo, right? So we only give it in the side of the upper thigh or in the anterior portion of the upper thigh because most of us have pretty good, padding, shall I say there. Okay, so a pseudo seizure. Okay. When I was practicing in Canada, we had this gentleman that used to come in and he knew tonic-clonic seizures, like a grand mal seizure. He knew it better than a patient who had epilepsy. And he would come in like that, and he just loved to have the drugs that we gave him to prevent the seizure. So we had neurologists come in and examine this guy, and he was admitted and he was put through every test in the whole book. He did not have a seizure disorder, but he really liked the Valium. At that time, we gave Valium more than midazolam, and he loved that. And he always wanted a prescription for it. So there is a difference between epilepsy and them trying to pretend that they have a bad seizure. So what is status epilepticus? That is bad. Now we're talking about big bad. It is a seizure activity that lasts longer than 5 minutes or recurrent seizures without a return to spontaneous consciousness, okay? They don't come back to consciousness and then they go back into another seizure. That's status epilepticus. What's happening in the brain? Is the brain getting enough oxygen and glucose? The answer is no, they're not. Okay, so here's some causes of status epilepticus. Brain tumors, like we talked about, a stroke, we mentioned head trauma, infections, okay, like our meningitis people, our stroke, cerebral vascular disease, maybe there's other things in our brain tissue, and there may be a malformation of part of our vascular system in the brain, and you're born with that. Okay, you may not even know you have that until somebody does like an MRI on your brain or something. And then you find out, oh, yeah, I have this malformation. And in that malformation, called AV, arteriovenous malformation, and you can bleed from that, it can be occluded, and then of course you would have a seizure. Hopefully you'd have a seizure before you go all the way out. So metabolic imbalances like we just talked about, low blood sugar, drug alcohol withdrawal, drug toxicity, hypoxia, autoimmune, and HIV infection. Okay, what do we do for it? Well, the one that we give the most, at least in LA County, is midazolam, or the trade name is Versed. We can give it IM into your vastus lateralis, that's your upper thigh on the side, or you can give it intranasally, or you could give it IO. And you see that the actual dosage changes. The other drug we can give is Ativan, okay, which is also a benzodiazepine and or Valium. Now, Valium is lesser used because of the possibility of causing respiratory depression. So midazolam is a newer drug and it doesn't cause as much respiratory depression. And as you know, the patient is postdictal for a while, so you want to make sure he doesn't have more problems to deal with his breathing by giving him diazepam. Magnesium sulfate is given for a seizure due to eclampsia, which I'm going to talk to you about. And then Keppra is a new drug that we give, and you probably heard Dilantin for seizures. And that used to be the only drug we could give until Keppra was introduced. So, in summary, then, we have talking about altered level of consciousness, how you're going to assess it. Then we've talked about some of the assessment and treatment of these altered patients: meningitis, different types, stroke and TIA, pre-syncope and then syncope, focal versus generalized, different kinds of seizures, and status epilepticus. And like I said, please know AEIOU tips, because we're going to be questioning you on them in the scenarios when you come to the paramedic school. And then, of course, hypoglycemia and seizures. So that's all I have for you with your neuro emergencies. And I hope you have a great rest of your day. Thank you. Bye.